anatomically located may have implications on what your physical exam findings are going to be and how you complete your physical exam. So most folks are anteroflexed, anteroverted, I should say. So they come up to the top, and we can feel the fundus when we do our bimanual exam. It's the retroverted and or retroflexed that really causes the issue because everybody's running more posterior. All right, let's start with puberty. Puberty is going to be this development of those secondary sexual characteristics. It often occurs over a 3-year period of time, and it's measured via Tanner stages. This is a graphical representation of the Tanner stages. We have Tanner stage 1 all the way to Tanner stage 5. 1 is pre-pubertal. We don't really have the breast development yet. We don't have the development of pubic hair. Stage 2 is when we're going to start having those breast bumps. So that's really the beginning of puberty. And then get all the way to stage 5, where that's full breast development and then full pubic hair development as well. Typically, puberty is going to start around 10 to 11 years old. That can certainly vary from ethnicity and where people live. There's actually been several studies out there that think that early onset of puberty is linked to obesity. One study that I've seen was on mice. But there have been other studies as well. But this study on mice says they thought that the issue is really related to leptin, because leptin is primarily produced in those fat cells, those adipocytes. And we normally will see, right, for young females that are not obese or not overweight, we normally will see these gradual increase in leptin levels. But for the patients, the young females that are obese, we have a sudden increase or significant increase, and that significant increase in leptin then seems to be our initiator of puberty. So those leptin deficient mice did not actually go into puberty, but those that had higher levels of leptin went into puberty earlier. So we may see that not only Hispanics or African Americans just by based on race, but also we may see earlier onset of puberty in those patients that are young females that are overweight. So some factors that affect the onset of puberty, certainly genetics. If mom had puberty early or later, then maybe daughter would have puberty early or later. Right? Nutritional state, as we talked about, obesity, maybe, or even patients that are malnourished. Those young females that are extremely athletic, are very thin, they oftentimes will have a delay in the onset of puberty. So parents are bringing these young patients in because they are early or late for their onset of puberty. When look at them, get their vital signs, get their BMI, and see if that maybe is related to that. Sometimes we've got these young females that are type A, super type A personality. A lot of stress that's associated with that. Maybe you know or feel that pain. And so stress itself may delay puberty. Usually doesn't cause an early onset. There's delayed puberty. And then just in general where people live based on the nutrition. So, I mean, not to pick on like the upper western, northwestern people, but they usually eat a lot healthier than, let's say, somebody who lives in New York City. That might be a latchkey child. So we may see that change. Regardless of when puberty starts, it typically is going to occur in a specific sequence. Okay, this sequence you can use this acronym TPUCMI. TPUCMI, I didn't make it up, it's just in the literature to help you remember this. So the T is thelarchy, we have adrenarchy, which is release of sex steroids. Pubarchy, we have peak growth velocity. Now peak growth velocity doesn't happen overnight, right? So this is a gradual increase in height. And then we have menarche towards the end. So the first sign of puberty then, with that secondary sexual characteristics, is going to be thelarchy, and that's that breast bud development. Occurs around the age of 10, and is consistent with Tanner stage 2. Again, that adrenarche, that's a release of those sex steroids. That's going to occur throughout puberty, not just one day, one period of time. Pubarchy, around 11 and a half years old, you're going to start seeing evidence of pubarchy, which is the development of the pubic hair. And we've got the growth spurt from around 10 and a half to 13 and a half, consistent with Tanner stage 2 and Tanner stage 3. Now, menarche, because oftentimes that's what brings parents in, because my child has not started their menstrual cycle yet. So menarche, we can tell the parents, should start around 2.5 years after the onset of puberty. So once we have the breast bud development, we would expect around 2.5 years later, we should have the onset of menarche. The mean age about 12 and a half or so for African Americans, 12.7 in Caucasian females. And we know that that can change depending on race, depending on BMI. Now, some girls, the first thing that we're going to see is puberty. That is still considered in the normal realm. That's not abnormal. Okay, so we're still looking for, thelarche to be our first onset sign of secondary sexual characteristics, but the puberty is the first sign, and that's okay as well. Think about the topography as our normal sequence. And all this is in relation to the HPO axis. There's the hypothalamic at the top in our brain, pituitary, and then we have the gonads, which are the ovaries, HPO axis. We have the constant release of GnRH from the time that we're born. It's a constant release. But around the age of 8 or so, the hypothalamus is going to start increasing the amount of GnRH that it's releasing. The issue is that the anterior pituitary gets a little bit resistant to that GnRH release. It's getting used to it. And so we have to have an increase in GnRH to affect the anterior pituitary. And then ultimately, what really kicks off puberty is the pulsatility of the release of GnRH. We talked about that yesterday when we talked about Kallmann syndrome. Kallmann syndrome, those young men and young women do not start puberty because they're having this inappropriate release of GnRH. We're not having this pulsatility. So for young females, they need to have that pulsatility in their GnRH to impact and affect the anterior pituitary. Once the anterior pituitary gets intermittently hit with these generations of GnRH, then it's going to start to increase the release of FSH and LH. Well, FSH and LH acts on what? It acts on the ovaries. So once we have that increase in FSH and LH, it's going to go down to the ovaries. We're going to have the increased release of estrogen, progesterone, a little bit of testosterone as well. And then ultimately, we're going to have the development of those secondary sexual characteristics. So if there's something wrong with anywhere in that HPO axis, we're going to see that because these patients are either going to have early onset of secondary sexual characteristics or late onset. But we can have early onset of puberty. We consider that patients that come in if they're less than 8. Again, this could be normal. We're going to look at family history and look at BMI. It often happens more in females than it does males. And if we identify that we don't really have a cause for this 7-year-old or this 6-year-old to start developing breasts, okay, then we can look for an underlying cause. So family history doesn't lead us to anything. They're not obese. We don't have any real reason for them to have an early onset of puberty. We can look for specific causes. And we classify those specific causes under central causes and peripheral causes. The problem is that despite accurate workups, appropriate workup in these patients, about 75% of the time, we're not going to identify a cause. It's idiopathic. So we're not really sure what the cause is. We just monitor these patients. So for you guys as primary care, then the question will be is, when do I send these patients to the pediatricians? If you're seeing pediatric patients, when do you send them for evaluation? Okay. Well, I will be honest with you. If I saw a 7-year-old with breast bud development or pubic hair development, I'm sending them, right? I'm going to let the pediatricians do the workup or get additional information because they're really the experts. So, I don't know, Air Force folks, Air Force, you guys see pediatric patients?
Yes.
Occasionally.
Occasionally?
We work.
Okay. So, Army folks, it'll be depending on where you're working, but most clinics end up seeing pediatric patients. So, I would use the threshold of 8, and if you're seeing anything earlier than that for the onset of puberty, then I refer those patients out so they can get a workup, or the pediatricians decide, sometimes they decide we're just gonna watch them. I mean, that's up to them, they're the experts in it. And so we got those central causes and the peripheral causes. Central causes, think about GnRH dependent. So something up here maybe in the brain, something's affecting GnRH in the way it's released. It could be idiopathic. They could have a CNS tumor or some sort of, maybe they had significant head trauma when they were younger, and that is impacting the hypothalamus. It could be iatrogenic. They had to have some sort of radiation or chemotherapy. Maybe infarct, depending on what their underlying medical conditions are. Okay, these patients that have a central or GnRH dependent cause, they're going to be female appearing. So they're going to look like young girls, but we're just having this early onset of puberty. Now, GnRH independent. We have something in the periphery that's causing the early onset of puberty. Oftentimes, it's associated with an excess release of estrogen, but we could also have an excess release of estrogen and androgen, and so sex steroids as well. Could be from thyroid problems. These patients may have an estrogen secreting tumor, or there's other diseases like McCune-Albright syndrome. That's a disease that can cause this. So something outside of the GnRH system, something in the periphery, is causing them to have an early onset of puberty. So it is GnRH dependent, that central onset, that central classification, that cause. We're just going to have early maturation or early activation of the HPO axis. We're still going to have the same sequence of development. So PURP, they will use that to accompany adrenarche, PURP, the same sequence, but we're just occurring earlier than normal. The gold standard for evaluating these patients in the best test is called the GnRH STIM test. Have you guys heard of that? Okay, so we just stimulate, it's a lab test that they do to assess GnRH. Other labs, LH and FSH. And LH and FSH are going to be high in these patients because we don't have appropriate negative feedback. So if LH and FSH are high, estrogen is typically high in these patients as well. We're just not having that negative feedback back to the anterior pituitary. How do we treat these patients? We can treat them with GnRH agonists. GnRH agonist, and that's going to inhibit the production of LH and FSH. It's going to reduce the amount of estrogen being produced as well. And I think that the treatment is interesting because we said that there's a GnRH problem, but we're treating them with GnRH. What's the deal? Why? Why do we think that this works? Because the problem is the pulsatility of GnRH. And the problem is the pulsatility. If we give them GnRH, we're going to keep that GnRH level equal, okay, even out, like we had before the age of 8, before the onset of puberty. So by giving them GnRH, we're keeping them on a constant level of GnRH instead of the pulsatility. And if we don't have that pulsatility, the anterior pituitary is going to go back and be resistant to that constant release of GnRH. If this is peripheral cause, so GnRH independent, okay, that means that the issue is not due to early activation of the HPO axis. The issue is something in the periphery, some sort of exogenous source of estrogen or androgens that are being released. We still can do FSH and LH, but also remember thyroid can cause this. We're going to add a TSH. And for these patients, the FSH and LH is typically low. Okay, they're having that elevated estrogens, but they're having the appropriate negative feedback to the anterior pituitary. Okay? So the anterior pituitary shuts down because the elevated estrogens are coming out of the ovary. For these patients, we have to figure out what the problem is, and we're going to treat that underlying problem. So if it's the fact that they have an estrogen secreting tumor, we've got to treat that. If they have a whole bunch of tumors or follicles or cysts on their ovaries, then we need to treat that. We've got to treat the underlying cause for these patients. The issue is if we don't treat or identify a cause and then treat the cause for early or precocious puberty, is significant delay or decrease in these patients' height. So again, these patients tend to be really short and short stature, and that's because we have premature closure of the growth plates. If we have premature closure of those growth plates, it's going to limit further growing after the onset of puberty in the first couple of years. We also can have, if someone is really short, then there's a lot of psychological stress that's associated with that. You guys in radiology, you guys hear about advanced bone age, So what that is, advanced bone age, well, first of all, what x-rays do they take to identify advanced bone age?
The physio plates?
So they take x-rays of a specific part of the body.
Joints?
Hand and wrist. Which hand and wrist? The left. Why? Because the majority, lefties, the majority of people are right-handed. And so if they fall, they're usually going to put up the right hand. So they're more likely to have trauma to their right hand and wrist, less likely to the left. Okay? And it doesn't mean if you're lefty they're going to do the right. It's still by nature of radiology they're supposed to do the left. So they do the left hand and they do the left wrist, and they're looking for that advanced bone age. And precocious puberty, they can have advanced bone age up to 3 years advanced, which means that they're not going to grow much more from the time that we see them. They're already 3 years advanced. So ultimately, the treatment goals are to help maximize the height. You want to be able to synchronize their puberty with their peers. And of course, we all know if you have kids do say mean things. Okay? So kids are mean. We can reduce the psychological stress associated with it. Okay? Mean duration of treatment, we're going to discontinue that typically around 11 years old. And that makes sense, right? Because that's the time they're going to start puberty anyway. And so we don't need to have them on this GnRH suppression forever or continuous GnRH forever. We want to have them just the amount of time so they can start puberty on their own in the normal time period. Now, sometimes we will have maturation just of single system. So we only have early onset of pubic hair. We only have early onset of PRP. Okay? This is really something that we're going to just assess these patients, see if there's something that's causing that. Otherwise, we check bone age. If bone age is normal, we just monitor these patients. If this is something you're doing in your clinic, that's great. Otherwise, you hunt them over to the pediatric clinic and they can continue to monitor these patients. So that's early onset. Well, we can have delayed onset as well. Lack of thelarchy by 13 years old, or a delay of over 4 years between thelarchy and the completion of puberty, or no menses by the age of 16. Now, I make the assumption that you guys are probably not going home at night, every night, reading Williams OBE and Williams GYN. I make that assumption, right? If you did read it, you may notice in that book, that's the book that we use for our reference guide. In that book, it says no menses by the age of 15. But we go with 16 because that's what the pediatricians go with, and that's really the guidelines that we need to go by. Okay, so no menses by the age of 16 is what we're going with. There's lots of different causes, but the primary cause is just a late bloomer. We have a little boy in our neighborhood, his name is Jeffrey. He's the cutest little thing, but he has the terriblest mouth. Oh my God, I'm telling you what. I'm like, I can hear you. I can hear your mouth over here. Anyway, he is cute, but he is so incredibly short. And they're in 10th grade, and he probably is, I don't know. I think he's grown this year, but he's probably like this tall. But I know he's getting there, because his parents are of average height, so eventually he's going to get there. He's just a late bloomer. And I think already this year, he's probably, he started this year, he's probably up to here right now, so I think he's getting there. So the majority of the time, it's just the fact that they're late bloomers. They're going to catch up, but just not necessarily today. Chronic anovulation. If that female is not ovulating, they're not having an increase in estrogen levels, that can cause a delay in puberty, because estrogen is a huge part of puberty and pubertal development. Okay? Breasts are very estrogen sensitive. We don't have a lot of circulating estrogen, okay, then these patients aren't going to have the onset of thelarchy and also may have other secondary sexual characteristics. You have something like AIS, or they could have some sort of anatomic problem. So anatomic means that they can still have the onset of some of those secondary sexual characteristics, but for the menstrual cycle, they aren't able to have the menstrual cycle, but they don't have flow outward because something is anatomically blocking that. Of course, if they're born without some of their Mullerian structures, that would cause an anatomic problem as well, right? We talked about that early on. It could be a hypo problem like Turner syndrome, or hypo, like some sort of CNS syndrome. Okay? Also think about the female athlete triad. And those patients that are really athletic, they're doing multiple sports in school, they're very, very thin. Those patients, it's not unusual at all for them to have a delay in onset of puberty. What we want to do, we want to do a really, really good history. This is a time when we sit down, we talk to both parents, we talk to the child. We need to get a really good family history, past medical history, social history as well. You know, is there any evidence throughout your history taking that this patient is extremely stressed out? You know, let's ask about their grades. Let's ask about what sports they're in, what is their nutrition, how much do they eat, how often do they eat, and that kind of stuff. Physical exam, we're going to look for the breast bud development, look for axillary hair as well. Okay, do they have excess acne anywhere? Especially if we notice that they have a little bit of excess hair, maybe on their face, maybe a bunch of acne on their face, upper chest, upper back, maybe something like PCOS. And PCOS certainly can cause a delay. We're going to do x-rays of that left wrist and the left hand to check for bone age. These patients have normal bone age or advanced bone age. And oftentimes we consider doing an ultrasound as well. Now these are young females, so using abdominal ultrasound would be appropriate. And what we're looking for is, do they have those Mullerian structures? Do they have the capability of even going in puberty? Check FSH and LH levels. Okay? And then the option could be we're going to watchful waiting, depending on what those x-rays show and how old these patients are. Or we might give low dose estrogen to help stimulate the onset of these secondary sexual characteristics. Oh, I was watching the History Channel a couple weeks ago, and I saw this 1919, this great molasses flood in Boston, Mass. Did you guys hear anything about that? You guys know about that? Yeah, so there's this, I didn't know, like molasses, I don't know, it's used to make alcohol. So this brewing company up in Pittsburgh or somewhere had millions of gallons of molasses that was in this town. So this specific barrel had 2.3 million gallons of molasses. And from what I remember on the History Channel, like people started hearing like rumbling. And it's like not that, I think like maybe a mile outside of town, but it wasn't like miles outside of town. And then next thing you know, the whole thing just kind of falls apart. It just, that doesn't explode, but kind of explodes. And molasses, it's like a mudslide. Molasses is coming at all these people. So it killed 21, injured 150, and for probably 30 or 40 years after this, people would say that in the summer, especially if it was really warm, they could still smell molasses. Still smell molasses. But that is insane. This is all, everything was destroyed in this town. This is all molasses that took over this town. You know, molasses is so darn sticky. Okay, happy days. Yes or no? Happy days, you know? Monday, Tuesday, okay, all right. I gotta do my trick. Okay. Arthur Fonzarelli, yes. But one thing that Arthur Fonzarelli taught me when I was very young is how to put coins on your elbow and catch it. Okay? So I'm going to do it. I only got 3, but when I was little, I could do 50 pennies, 2 stacks of 25. I'm not joking. I could do it. But I only got 3, so watch out. Let's hope I can do it. I know, watch out. and then my arms are on. Like, I have done that, like, that's such a good party trick, too. I have done it since I was little, and I was like, oh my God, today is the day I get to do it. And this year in 2009, truly a miracle on the Hudson. Truly a miracle on the Hudson. You guys know all about Chelsea Sullenberger and his U.S., I think it's Airways, Airlines, but anyway, he was able to land in January, in the Hudson. Like, you know that those guys had to be freezing to death, but they all survived. All right. Oh, so that brings us to the menstrual cycle. The menstrual cycle. The menstrual cycle can be very convoluted, but it is very important that you understand the menstrual cycle because patients are going to come, parents are going to come to you and talk to you about the menstrual cycle, but not just parents, 20-year-olds, 21-year-olds, 17-year-olds. I came in the military when I was 17 years old. So those patients are going to come to you and ask you, like, why am I not having a cycle? Why am I having it more often? Maybe you have 2 uteruses. Let's talk about that. So menstrual cycle, the average frequency, how often it occurs for menstrual cycle is about 28 days. Now it's plus or minus 7, so it could be 21, could be 35 days. The average about 28 days. Typically lasts around 3 to 7 days. As patients get older, the time period that lasts typically less and less and less to the point where they don't have a cycle at all, and then they go into menopause. Average blood loss, 20 to 60 mLs. And I think that's pretty amazing because you guys know what a like a 10 cc syringe looks like, right? The majority knows a 10 cc syringe like. Well, that's 6 of those. And I will tell you, some of these patients, when you talk to them, they're like, we only lose about 60 mLs. Like, that's absolutely, there's no way. I lose way more than that. But on average, it's up to 60 mL. So not a tremendous amount of blood loss per cycle. There are patients certainly that bleed a lot more and can become very anemic on the menstrual cycle, but in general, about 20 to 60 mL. Most cycles are regular during our normal reproductive time period. So once we have complete maturation of our HPO axis, we start to have regular cycles. Okay? But they're most irregular at the very beginning, so those first couple of years of the menstrual cycle, and at the very end as patients are going more and more towards menopause. We don't have as much circulating estrogen, our hormones are all off whack, and so we're going to have changes in those menstrual cycles at the earlier onset and then the later. And it's all in relation to this HPO axis. So the HPO axis is a major regulator of female hormones. We know that we have GnRH that's released from the top. GnRH, we know, affects the anterior pituitary. FSH is released, and we go down to the ovary where we have estrogen and progesterone that's released. In the menstrual cycle itself, we can think of this as kind of 4 integrated subcycles. We have the hypothalamus, we have the anterior pituitary, the FSH, LH, we have the ovaries, which estrogen, progesterone, a little bit of testosterone as well. And then at the endometrium, we have the shedding of that endometrial lining. That is our bleeding phase, essentially, of the menstrual cycle. The first day of the menstrual cycle is considered that first day of shedding, the first day of onset of bleeding is going to be considered our first day. And we choose that kind of arbitrarily, but also kind of not. Meaning, if you were to talk to most females and say, when was the first day of your menstrual cycle? They will be able to tell you. And if you talk to most females, they say, when was the last day of your menstrual cycle? Well, I had a little bit of bleeding, and then I didn't have, and then I did again. So there's just too much confusion because usually for the menstrual cycle, it slowly goes away. First couple of days are pretty heavy, and then after that, it gets lighter and lighter with some spotting. So it's much easier to identify the first day than it is the last day. We already know that we have all the eggs we're going to have at the very beginning of birth. 1 to 2 million eggs are present at birth, and then about 400,000 or so at puberty. And each female, the normal reproductive time period, is going to have about 400 ovulations. We have 2 primary phases that we talk about associated with the menstrual cycle. We have the follicular phase, that's also known as the proliferative phase. Lasts around 14 days. It begins at the first day of the menstrual cycle and ends at ovulation. It is variable. And the reason why it's variable because it all depends on estrogen and when estrogen peaks, and then ultimately that can lead and will lead to ovulation. So estrogen is going to be our primary hormone during this phase. Okay? We have the early follicular phase, and that's also going to be considered your bleeding phase, your menstrual phase. That's from days 1 to 5. Here we have shedding of the endometrial linings, we have decrease in estrogen, we have decrease in progesterone. Okay? And then we have the late follicular phase. So once the bleeding phase is done, around day 6 to about day 14 or so, we're going to start to have proliferation of the endometrial lining. The endometrial lining will start to get thicker and thicker and thicker, really in preparation for a potential implantation to occur. Okay? And during that time period, we have increased in estrogen primarily, and then a little bit start to rise for our progesterone as well. Okay, now, we have FSH that's being released from the pituitary gland. That's kind of consistently from the beginning, but we have an increase related to these primordial follicles. We have about 5 to 15 primordial follicles, but really one dominant follicle is going to, so it's like the survival of the fittest, right? That one dominant follicle is going to develop and it's going to mature until the time of ovulation. What that follicle does, though, is extremely important. That follicle kicks out estrogen, and it kicks out estrogen by virtue of using the theca cells and the granulosa cells. So for the theca cells, those are the ones at the outside of the follicle. They are going to work and convert cholesterol into androstenedione, and that is in concert with LH. And then those granulosa cells, what they're going to do is they're going to take the androstenedione. The androstenedione, that's a steroid. Okay, they're going to convert the androstenedione into estrogen. And we need estrogen because if we don't have enough estrogen, we are not going to ovulate. This patient is not going to ovulate if we don't have enough estrogen. And that's all in response to that increasing FSH. So FSH helps to kick out that estrogen, but it's because of the cells that surround the dominant follicle. So then around day 14, we're going to have that increase in estrogen. But it's not just a little bit of increase, it's a significant increase in estrogen. Estrogen must reach a certain threshold. And you don't need to know the number, but it's about 200 picograms. If estrogen doesn't reach that 200 picograms, guess what? We don't have ovulation. So as long as that dominant follicle is secreting FSH, estrogen is being released, we get to that 200 picograms, that is our peak, then we have the LH surge. And the LH surge is a sudden increase in LH over a period of about 12 to 24 hours. That LH surge is what ultimately leads to ovulation. Okay, so LH surge about 12 to 24 hours, and then ovulation occurs about 24 to 36 hours. Now, once the egg has been released, once ovulation occurs, that egg must be fertilized within 24 hours of release. And if it's not, it degenerates, it goes away, and we do not have implantation. Okay? So the keys of this, you have to remember, is if we don't have enough estrogen, if that estrogen doesn't get all the way to this peak, LH will not surge. If we don't have an LH surge, the patient will not ovulate. It will not ovulate. So we've got our follicular phase. In that follicular phase, we already talked about this, the beginning of your menstrual cycle. Okay, the 1 to 5 is the bleeding phase. Okay, so that's the early portion of the follicular phase. And then with the late, that's that 16 to 14 or so, where we have increased estrogen, a little bit increase in progesterone. So we've got that significant estrogen peaks, causing that LH surge to occur. And then after the LH surge, a day and a half or so, we're going to have ovulation. Now, after we have ovulation, then we have the luteal phase. The luteal phase is also known as the secretory phase. We have things that are secreting. We want to make the endometrial lining a nice, comfortable place for an egg to grow. And so we've got things that are secreting. This is around days 15 to 28. Okay, and it begins a day or two after the LH surge. So kind of the follicular phase ends at ovulation. This begins at ovulation. And it ends with the first day of the menstrual cycle. And this lasts around 12 to 14 days. It's a more defined phase because it's based on the corpus luteum. The corpus luteum is what develops around that egg, right? And the corpus luteum lasts about 9 to 10 days. If we don't have fertilization, that corpus luteum is going to degenerate, it's going to go away. So here it's a more defined phase. The follicular phase, because it's primarily waiting for that increase in estrogen, it can be more variable in phase. Our primary hormone in the luteal phase is progesterone. Okay, and the progesterone, what it does is it secretes, causes the endometrial lining to become more glandular, and those glandular cells are going to secrete hormones and help make sure that the endometrial lining is ready for implantation for the egg. The glycoproteins, glycogen, that's what's being released. So if we have fertilization that occurs, we had our LH surge, we have ovulation, we have fertilization that occurs, then what we have is we have a development of a trophoblast, a small embryo. And that trophoblast job is to kick out HCG. Okay? HCG maintains the corpus luteum. Okay? And we need that corpus luteum around because guess what we don't have at this point in time after we have the fertilization? We don't have a placenta. We don't have a placenta. We don't have a placenta really until on the end of our first trimester. Okay? And we have a kind of a really little placenta that's providing the nutrients. So the corpus luteum has to be kept around to promote gestation. Okay? So what does that corpus luteum do? That corpus luteum kicks out progesterone. Okay? So we've got our trophoblast that's kicking out HCG. Okay? HCG maintains the corpus luteum. The corpus luteum kicks out progesterone to promote gestation, and that maintains the endometrial lining. Because again, the luteal phase, the primary hormone is progesterone to make the lining of the endometrial thick and nice for implantation. The corpus luteum is going to take place of that placenta until that placenta develops and can provide nutrients to the baby. If we do not have fertilization, then that corpus luteum is going to degenerate. It's going to go away. Our progesterone levels are going to decrease because we no longer have that corpus luteum that's kicking out progesterone. So our progesterone levels decrease, the endometrial lining is not maintained, and we start the beginning of the cycle. Convoluted? Convoluted. It's a lot. It's a lot of things. Okay, so when we talk to our patients about this, these are the things that we have. Why is this not working well? Why are these things happening? We've got to understand the pathophys ourselves in order to explain. I talked to you guys yesterday about education, educating our patients. That means we got to educate ourselves as well. Okay? So let's look at this in a pictogram. So we've got the first part of this. We've got a follicular phase here, luteal phase, cycle without conception. Okay, and we have a line that comes down here, and we've got our follicular phase. We've got a cycle with conception. So the first thing that we're going to notice, okay, we come down here, we've got our menstrual cycle here at the bottom. Okay, we've got our menstrual cycle, we've got our little follicles, okay, but once our menstrual cycle is over, we're going to notice we've got thickening of the endometrial lining. We've got thickening of the endometrial lining, okay, that proliferation is going to occur because we have this increase in estrogen. So our first phase, follicular phase, we have a primary hormone is estrogen. We have a little bit of progesterone that increases as well. We have that estrogen. Once that estrogen gets all the way up to that 200 picograms or so, right after that, we come up here, we have that LH surge. Prior to that, we do have an increase in LSH a little bit. We do have that increase, but really, we have that sudden increase in LH. If that estrogen doesn't get to that level, we're not going to have that LH surge. We're not going to have ovulation. For this patient, we have ovulation. We have that LH surge for about 12 to 24 hours. And then a day or day and a half later, we're gonna have ovulation that occurs. That brings us into our luteal phase. In our luteal phase, we've got, that's our secretory phase. We've got those glycoproteins that are being secreted. And here we have that increase in progesterone because our progesterone is our primary hormone in our luteal phase. We have the development of the corpus luteum. That corpus luteum develops around the follicle. Okay? Its plan is to keep that follicle in place and help that follicle grow. That's the plan, right? But what happens is we don't have fertilization. So we don't have fertilization, that corpus luteum is going to be X'd out, it's going to degenerate, it's going to go away. We can't keep around the progesterone, so the progesterone is going to come back down to baseline, and we're going to start this cycle all over again. And that is without conception. If we have conception, we start off the exact same way. We still have estrogen as our primary component in our follicular phase. We still have progesterone as our primary component in our luteal phase. But the difference is our corpus luteum doesn't go away. The corpus luteum gets bigger and bigger and bigger. It's kicking out progesterone to promote gestation, to keep those trophoblasts alive, to keep those trophoblasts alive, right? So the trophoblasts are kicking out HCG. Okay, HCG is important, right? And so then we have HCG that's keeping the corpus luteum around. The corpus luteum is taking out progesterone, promoting gestation, and then around 8 to 10 weeks we have the development of the placenta. The placenta then will take over responsibility for that nutrient. Okay? Yes? No? Maybe you got to think about it. We'll think about it. Let me know if you have a question. Now, that brings us to anovulation. What happens if someone is not having that amount of estrogen that we need? We're not having the LH surge. Okay, they're not ovulating. Ultimately, the ovary doesn't produce that mature follicle, so we're not ovulating. These patients, it's like 51st days. They are stuck in the follicular phase. They go back and go, I'm trying to get, I can't get there. I'm trying to get to, I can't get to the luteal phase. No luteal phase occurs because we don't have ovulation. The estrogen levels are not getting up to where we need them to be. So then we have no corpus luteum formation. We're not going to be able to have fertilization because we don't have a release of the egg. So these patients with anovulation, oftentimes they'll come in complaining that they've been trying to get pregnant, but they haven't been able to get pregnant. These patients are going to remain in that follicular phase, but here's the problem. They will actually bleed sometimes. They will actually bleed. It's not that they're having a menstrual cycle. Excuse me. It's not that they're having a menstrual cycle, but what happens is this. We know that estrogen proliferates, right? It thickens the endometrial lining. Okay? So we'll have it thickening. Estrogen levels are up here. They're about 150 picograms, but they're staying there. So we'll still have that thickening of the endometrial lining, okay, and it stays thick. Eventually, it outgrows the blood supply. The blood supply gives up. And that area, that top area of the endometrial lining that's not getting blood supply to it is going to slough off. And it's going to slough off in the form of a menstrual cycle. People think it's a menstrual cycle because it's bleeding from the vagina, right? So they're like, well, I must be having my menstrual cycle, but it's going to be at irregular times. So when you talk to your patients, well, do you have regular menstrual cycles or irregular? If they say they have irregular menstrual cycles, that's abnormal. That is anovulation. They are not ovulating for some reason. Okay? So think about it as a plant. Yes?
I was just curious, does this same cycle happen for patients who are like artificially anovulating due to like a birth control medication regimen?
So depends on what birth control they're on. Okay. What usually happens with birth control is they take them off a medication. They have like a placebo week. Okay, so during that placebo week, then it allows them to have that menstrual bleeding. So they are not ovulating still, but once they take the hormones away, they're having a hormone withdrawal bleed, similar to what this is. And this is, you have this estrogen, okay, so it's not really a hormone withdrawal, but you're not having that ovulation that's occurring. With the birth control, you're having a hormone withdrawal bleed, but they're still anovulatory. Well, depending on the birth control, like if it's progesterone only, doesn't specifically focus on that. But depending on the birth control, the whole point of it is so that they're not ovulating.
Right.
So similar, not quite the same, because those birth control methods usually don't have thickening of the endometrial lining like we have here.
Okay.
Right? So think about it as a plant that's in the bucket, and you're just, like, I want my plant to be really, really, really big. Fertilize. Well, it's growing great, but it's outgrowing the bucket. Okay, this is outgrowing the endometrial, the blood supply that supplies. So that top layer is going to slough off. Okay? When they slough off, they're thinking they're having no menstrual cycle, but they're not. And that's why we ask you, if you are ovulating, your cycles are going to be the same time. Every 28 days I have a cycle. Every 29 days it's going to be the same. If you're not ovulating, it might be every 6 weeks, it might be every 8 weeks, or every 3 months. It's going to be irregular. So this is our normal menstrual cycle is a progesterone withdrawal bleed. This is actually an overgrowth of estrogen. You got either too much estrogen. This is bleeding due to too much estrogen. Estrogen withdrawal, essentially. And so these patients, the number one thing they're going to complain of is irregular menstrual cycles, or ultimately the blood supply gives up, or they can't believe they ultimately over months and months they don't have a cycle at all. It's called amenorrhea. Okay, that's the most common cause of secondary amenorrhea actually is anovulatory cycles. Okay. So we definitely see anovulation at extremes of age. So we see it very early on when the HPO axis is immature. And as someone is going towards menopause, they have mixed ovulatory and anovulatory cycles. Okay, so it's more common then. And usually it's something that's affecting the HPO axis. But it also could be some sort of systemic disease like thyroid, poorly controlled thyroid, hyper or hypo. Okay, more commonly hypo, but definitely can occur with hyper as well. Celiac disease. And we want to make sure that we understand this is a diagnosis of exclusion. We do labs on these patients. We do an evaluation. We can't identify any other etiology for their abnormal cycles. So it's not just, oh, you have irregular cycles, you must have anovulation. There's nothing here. No, we're going to work these patients up and make sure that there's nothing else. It's a diagnosis of exclusion. All right, let's take a break. We have primary amenorrhea, and these patients are primary amenorrhea. We've got specific definitions for that. So no menses by the age of 16, but they have normal secondary sexual characteristics. No menses by the age of 14, but they do not have evidence of secondary sexual characteristics. Or no menses within 3 years of PYP. We can have secondary amenorrhea. What secondary amenorrhea is, they used to have menstrual cycles, but now they're not having menstrual cycles any longer. And so normally have menstrual cycles, whether they're regular or irregular, they still used to bleed, but now they're not having any bleeding at all. Now all causes of secondary amenorrhea can cause primary amenorrhea, but that is not true the other way around. Okay. So if you think of a cause of primary amenorrhea that we've already talked about, very first lecture, we talked about structures, the Müllerian structures. Well, if you have a uterus, you're never going to have a menstrual cycle. That means you can't have primary etiologies can't cause secondary. You never had a uterus, so you couldn't have had a menstrual cycle to have secondary. But secondary causes like PCOS, that could cause primary amenorrhea. That can also cause secondary amenorrhea. So that's what I mean by that. There's a lot of disorders that we think about that can cause amenorrhea. Okay? Sometimes it's associated with abnormal gonadotropin levels, so FSH and LH, and Turner syndrome, Kallman syndrome. Sometimes we have normal FSH and LH levels, like eugonadism, okay, but we have other abnormalities like PCOS, like the Müllerian agenesis. Müllerian agenesis is not going to affect your anterior pituitary. And remember, the Müllerian structures does not include your ovaries, so your labs often look normal, but they just don't have the structures. Okay, if someone has an imperforate hymen, their labs are going to look okay, okay, but they don't have an outflow problem. Okay? Or we could have something that affects causes low FSH, low LH, so we have hypo. Okay? And that could be certainly constitutional. It could be stress, anxiety. It could be someone, the way that someone's eating very, very thin. Okay, that can cause this. Pituitary disease can cause this. CNS disease can cause it as well. So we kind of break it up into hypo, your normal, your eugonadism, normal FSH and LH, and then we've got our hypo as well. The most common cause of secondary amenorrhea is going to be pregnancy. Despite what your patient says to you, there's no way. It's impossible. It's no way. I know I haven't even had sex. Not possible. But the pregnancy test is possible. Now I will tell you this, from a personal perspective, if they've gone to the corporate and said, I'm not, and they are, don't go in that room by yourself. Don't go in that room by yourself and tell them, right? Because you don't know what's going to happen. And not that they're going to beat you up, but psychologically they've already convinced themselves they're not, and now you're telling them that they are. There might be a little bit of upset, a little bit of chaos going on, right? Okay. So the second most common cause of secondary amenorrhea, anovulatory cycles. Okay, anovulatory cycles. Okay, we can have something called functional hypothalamic amenorrhea. I would highlight that, I would circle that. It's not underlined, but if I was you, I would underline it. Functional hypothalamic amenorrhea. Okay, this is usually due to stress, usually due to that excessive exercise. These patients that are very, very thin or they've lost a significant amount of weight or less than 10% ideal body weight, nutritional deficiencies, leptin deficiency. Leptin is going to be in those adipocytes. And so that can cause functional amenorrhea as a common cause of anovulatory cycles and secondary amenorrhea. PCOS. PCOS, we have high circulating androgens, then can cause primary or secondary amenorrhea. And then if we have elevated prolactin levels, so something that is suppressing the GnRH. If we have suppression of that GnRH, then ultimately we're going to have decreased FSH and maybe decreased estrogen progesterone as well. So for these patients that have suppression of the GnRH, low to normal FSH level. And then we've got a whole host of things over here. I'm not a big person that makes you memorize things on a chart. They're on a chart for reasons so we can look them up in the book when we have a question. So I wouldn't really focus on what's on all the stuff that's on this chart. I just would certainly remember some of these secondary causes and functional hypothalamic amenorrhea and one of the primary things. Of course, you want to get a pregnancy test in those patients to make sure the inside of the uterus. So a whole host of things. And again, I would probably focus on these primary labs. The secondary labs are going to be based on history and physical exam. So if someone comes in, their primary amenorrhea, you guys know how to read a flow chart. I don't have to read this flow chart for you. Right? But you're going to do your history and physical exam. You're going to look for signs of secondary sexual characteristics. If you do not have signs of secondary sexual characteristics, well, now we've got to, let's get some labs, like that FSH. And if that FSH is abnormal, okay, then we also look at things a little higher. So we're looking at the pituitary. We may have to look at the hypothalamus as well. If our FSH is low, there's something up above maybe that's causing the FSH to be low. Why is that FSH low? So we're going to look at that. We'll look at low versus high. If we do have signs of secondary sexual characteristics, okay, we're going to do that pregnancy test. If it's negative, then we can do some imaging. And there's nothing wrong, really with doing labs for all of these patients to get a better idea of what's going on. If they come in and they have secondary amenorrhea, so if I was a betting person, I would bet that you need to focus on this chart more than you need to focus on the other chart. Okay? So these patients are still going to do the same thing. We're going to do history, we're going to do a physical exam, and we're going to get some basic labs, a pregnancy test, TSH, prolactin. If that prolactin is super high, we got to look up high. We got to look in that hypothalamus. We got to do an MRI of the brain. Okay? If we have thyroid levels that are abnormal, maybe this is thyroid disease. We can treat that with medication. And then, if all of it is normal, our labs are normal, we can do something called the progesterone challenge test. A progesterone challenge test, what we're doing is we're giving these patients progesterone. Usually it's in 10 milligrams a day for 10 days, but we like to know the amount of medication and for how long. Okay? But if I'm giving somebody progesterone, which phase of the menstrual cycle am I replicating? Luteal phase. I believe the primary hormone in the luteal phase is progesterone. So what I'm assuming then, if I'm giving them progesterone, okay, I'm assuming that what's not happening? They're not ovulating. They're not going to that luteal phase. So I'm going to make them go to the luteal phase. I'm going to push them into the luteal phase. Okay? If I have bleeding, they're probably not ovulating, maybe due to some way PCOS. Okay? If I do not have bleeding, the next thing I can do is I can do this estrogen progestin challenge. So if I'm giving somebody estrogen and progesterone, what part of the menstrual cycle am I replicating? All of it. All of it. If I'm giving you a fake menstrual cycle by giving you medications, I should have bleeding. I am overcoming everything that's inside that patient that's not causing this bleeding. I'm overcoming that by giving you the medication. And I should force you into a menstrual cycle, right, by giving you this medication. So if I have withdrawal bleed, then we're going to check some more labs. We're going to check that FSH. Okay, if that FSH is really high, so if FSH is really high, okay, what is the problem? Is the problem at the hypothalamus? Is the problem at the pituitary? Or is the problem at the ovaries? The problem is at the ovaries. Ovaries are not responding, so we call that hypergonadism or hypergonadotropism. Ovaries are not responding, so that anterior pituitary still kicking out FSH, still kicking out LH, right? So we're going to check that FSH. If it's super high, we may have a problem at the ovaries. Okay, we got to figure out what that problem is. What's going on? Maybe these guys are in the 30s, late 30s, 40s, and they're kind of perimenopausal. Okay? But otherwise, we got to figure out what the deal is. Why the ovaries not responding? If that FSH is low, is this a thin patient? Are they really stressed out? What is, they got 10 kids at home, and, husband works or spouse works all the time, so we got to figure that out. If I do not have a bleed, I've given this patient a menstrual cycle, and they do not have a bleed, outflow problem. And we're going to look for an outflow problem, see what's going on there, because I just replicated everything. I'm not asking the body to do anything. I'm asking the body only to respond to these hormones appropriately. So that's what our evaluation is, and you'll see secondary amenorrhea a lot more than you'll see primary amenorrhea, which is why I want you to focus on it. All right. Now, dysmenorrhea. These patients are having a menstrual cycle, but it's so painful, so painful. We typically have cyclic pain in and around the time of their menstrual cycle. Most patients will describe this as cramping in sensation. Oftentimes they have other associated symptoms like low back pain, nausea, vomiting, some patients have diarrhea, headache, and just like we saw previously, we have primary and secondary dysmenorrhea. Okay, primary and secondary dysmenorrhea. Primary and secondary dysmenorrhea. Primary dysmenorrhea, for these patients, we think about cyclic menstrual pain, probably from the beginning of when they started their menstrual cycle. They've been having pretty significant pain with every single menstrual cycle. Okay, and we don't really have specifically identify an underlying pathology. Okay? What happens for these patients, you know, for all patients that have a menstrual cycle, they have release of prostaglandin levels at the lining of the endometrium. So release of these prostaglandins, and prostaglandins would cause endometrial inflammation. So all of these patients have release of prostaglandins, but the thought for these primary dysmenorrhea patients is they might be super sensitive to the release of those prostaglandins. Okay. So before I move on to anything, have you guys learned in pharmacy a medication that inhibits prostaglandins? What? Yes, but are anti-inflammatories? Do they inhibit prostaglandins? Yeah, that's the word. That's the word. So anti-inflammatories tend to inhibit prostaglandins, right? So these patients, they tend to have higher prostaglandin levels, and they have more inflammation associated with that. And we can manage those patients usually with a prostaglandin inhibitor. So secondary dysmenorrhea, usually we're going to see this in older patient population. I say older. You know, it might be in their 20s and 30s, but older than their teens, you know, so they're several years out the menstrual cycle. They used to have menstrual cycle, and they didn't really have that much pain, but now as they've gotten a little bit older, more menstrual cycles under the belt, they're having more and more pain. Endometriosis is a common cause of secondary dysmenorrhea. Problem with endometriosis, it typically takes 10, 15, 20 years for someone to diagnose. It takes forever. Okay, so anybody that comes in with secondary dysmenorrhea, you want to have that on your differential. Fibroids can cause adenomyosis, and some of these words are probably foreign to you. It's okay. We will cover these with. Adenomyosis is you actually have endometrial glandular tissue that's in the muscle of your uterus. So that doesn't sound good, right? PID, so if they have an infection, certainly that can cause pain. And then if they have an outlet obstruction. So here, we're not really sure these patients, yes, they definitely release prostaglandins, but we're not really sure that that's the issue, because usually they just still have a little bit of cramping, but not significant. And for these patients with this secondary dysmenorrhea, depending on what the cause is, they may have pain not only in and around their menstrual cycle, it may be maybe get to the point where they have it all the time. It's been going on for quite some time, especially it's related to like endometriosis. Oftentimes they have other associated symptoms. They have discomfort, sometimes with urination, sometimes discomfort with bowel movement, we call it dysphagia. Dyspareunia is painful intercourse. They oftentimes have multiple other complaints associated with it. And it's up to you guys to be able to pull those other complaints out. Well, if you happen to have pain with urinating or defecation or with intercourse. So how do we identify this? How do we diagnose it? Well, really just menstrual cramps. So they're coming in with this crampy type of abdominal discomfort in and around the time of the menstrual cycle. And if really they're just complaining of menstrual cramps, they don't really have maybe that nausea, vomiting, headache a little bit, they don't have any other secondary signs or symptoms, we can just treat them with something like an anti-inflammatory. If we do a good history on these patients with physical, and we identify that they maybe have multiple sexual partners or high risk for infection, we might want to consider evaluating them for gonorrhea, chlamydia, bacterial infection, PID, something like that. So that would entail more of a GYN exam in addition to the history of the physical. If you're not able to complete the pelvic exam because it's too uncomfortable for these patients, okay, then we can consider something like radiology, so transabdominal or transvaginal ultrasound can be done. And it helps us identify a couple of things, not really endometriosis, but certainly you can look for PCOS, it can look for structural abnormality as well. There will be a primary dysmenorrhea. The initial and preferred treatment is going to be an anti-inflammatory to reduce those prostaglandins. But we can also put these patients on combined oral contraceptives. How do you think, anybody understand why combined oral contraceptives? So combined oral contraceptives is going to be estrogen and progesterone. Okay, why might that work? Any idea if we have estrogen and progesterone? Well, we won't have as much release of those prostaglandins, right? Because we're not having the thickening of the endometrial line. If you have on estrogen and progesterone, we're reducing those hormones. Okay, we're reducing those hormones, or making them, I should say, not reducing, but we're making them steady. So instead of we have an increase in that estrogen, increase in that progesterone, we're really giving a steady state of hormones, and so we're not having that thickening, we won't have that inflammation. Something like progesterone-only contraceptives can work as well, and ultimately how they work is they'll start to thin the lining of the uterus, and so we don't have the prostaglandins. So the end result is still the same, it's just how it works is different. We don't have the prostaglandins that's causing that inflammation. And then secondary to dysmenorrhea, we've got to really try to identify the cause. Is there an etiology? In the interim, these patients can still go on anti-inflammatories. Okay, they can still go on combined oral contraceptives or progesterone-only contraceptives and do all of that while we're working them up. And then the literature does talk about anti-inflammatories. So which anti-inflammatory is best? There's not really a best anti-inflammatory. So it could be naproxen, you could use ibuprofen, it doesn't really matter. But you want to use the appropriate dose. So we're not doing 200 2 times a day, we're at that 600 2 to 3 times a day. So we want to use the appropriate dose for these patients. If they're already on ibuprofen, there's really no benefit to switching them to naproxen. The studies don't show any different. So that leads us to something called toxic shock syndrome. I could put this anywhere, I just put it here because we're talking about the menstrual cycle. For many years, we thought about toxic shock syndrome in association with tampon use during the menstrual cycle. And really, this was initially identified back in the late 70s. I know y'all are like, oh, that's a long time ago. Well, not for me, it was a long time. But late 70s, we had multiple deaths that occurred because of toxic shock. So it came to 1978 and then really became very public in the early 1980s. And this toxic shock affects about 1 in 100,000 people. So not a tremendous amount, but in the early 80s we had several deaths specifically related to the composition of the tampon. So back then, when they said super absorbent, they meant super absorbent. Like it was designed to be in all day, designed to be used all day long and without any leaking. Okay? So the composition of the tampon then held on to these exotoxins, the endotoxins, the exotoxins, and that's what created this toxic shock syndrome, this infection. So we might see this a couple of days after the onset of menstrual cycle. But nowadays we see with other things as well. Sinus surgery is a big cause of this. The sinus surgery, they have packing in there, or if you have to pack anything else, anytime you have to pack anything, that increases the risk of toxic shock syndrome. Classic presentation for these patients: fever, malaise, diarrhea. They can get this red, what it looks like a terribly painful rash. It's kind of macular-papular rash, but it's not painful at all. Usually a week or 2 later, they're going to start to have skin desquamation. So hopefully that's not the time where we should be seeing them probably well before that. You're going to be seeing more of that fever, malaise. Well, guess what? We're in cold and flu season. This flu season has been terrible, absolutely terrible. So if I saw a patient that came with fever and malaise today, I'd be like, you probably got the flu. And I don't test a lot of people for the flu because there's nothing really to do about the flu. Send them home, let them rest. So if this person came in, I very well could miss it. But most of the time, by the time they come in, a day or 2 later after their fever started, they have this rash. And the rash is kind of your key, not really the skin desquamation. Certainly their vital signs. So they have hypotension, tachycardia. And even if they're not febrile then, you always want to think about fever and tachycardia. Does the amount of tachycardia coincide with the degree of the fever? Let's treat the fever, we should have improvement of that tachycardia. For these patients, it would not improve. Okay? And then treatment is going to be antibiotics for these patients. We don't wait for the culture, we give them broad spectrum antibiotics, and then support with IV fluids, electrolytes, things like that. Unfortunately, even if we get these patients coming early on, we have the appropriate treatment, still about a 5% death rate today. So our criteria, we've got that fever, rash, skin desquamation, we have hypotension. But usually we're looking for multi-system involvement. Okay, so GI stuff, so, muscle weakness and fatigue, We can have some hematologics. We're looking at our labs for this, our CBC. And then the laboratory criteria, culture. These patients, what we're going to do is we're going to start that empiric treatment. The empiric treatment, prophylactic, we're going to just give that right up front as soon as we identify that this might be the etiology. A little bit of vape probably didn't hurt too many people, except if you have an allergy. What's the allergy? What's the main allergy to vape?
The rash.
Red man syndrome. The red man syndrome. Oh, you can learn so much. Not so much. Clindamycin. So vanc, clinda, and then one of the other following. Vanc, clinda. The key with these, I don't need you to memorize these antibiotics. I need you to memorize, I'm not waiting for the culture. I'm giving, this person comes in with signs and symptoms of toxic, or concerned about toxic syndrome. I am not waiting for the culture. I am giving them empiric antibiotics. And then can adjust based on the culture. So the last thing we'll talk about is menstrual associated psychologic disorders. Menstrual associated psychologic disorders. So we have two primary ones. The first one is premenstrual syndrome. Premenstrual syndrome. So these patients, that's about 20% of women. They tend to have a whole host of kind of mild to moderate signs and symptoms. There's about 300 different signs and symptoms these patients might present with. But the most common is fatigue around the time of my menstrual cycle, maybe a couple of days before, and then a couple of days into the menstrual cycle, and fatigue. I have labile moods. I'm happy, I'm sad, I'm happy, I'm sad. Breast tenderness. I want to eat everything in sight. Those kind of things can happen. And so we have, again, multitude, over 300 different symptoms of fatigue, bloating, labile mood. Those are the most common things that we're going to see in these patients. So PMS presents like that. Premenstrual dysphoric disorder is those same kind of symptoms, only on steroids. So these symptoms that these patients are having is affecting everything that they do. Okay? But not every day of their life. Okay? It's going to occur usually in the second half of the cycle, in that luteal phase. Okay? And again, it interferes with their quality of life. These patients are not grumpy every day of their life, but they need to have this 7 days that are symptom free. So during the last half of the luteal phase, they're going to start to become a little bit grumpy, and then they start to become really grumpy and really sad. I can't go to work. I can't get out of bed type of situation. I lost relationships over this because I feel so terrible during this time period. Okay? And then at some point, all those symptoms completely go away for at least a week. And then we go back to the same issue, the second half of the luteal phase. We're having those same problems. We're not really exactly sure why some people have PMDD and others don't. Okay? We're not sure, but we know that maybe it's related to estrogen and progesterone. So estrogen and progesterone are kind of neurosteroids of sort. Estrogen would excite people, progesterone kind of calms people down. So it might be that they have this really high sensitivity to the estrogen and progesterone, and a change throughout the month of the estrogen and progesterone levels. Most of the time, we will find that these patients do have an underlying psychological disorder of some sort, major depression, something like that. They have some sort of additional psychological disorder. Also, patients that have diets high in sugar, high in caffeine, they tend to have an exacerbation of their symptoms, even worse than the normal PMDD. So PMDD, think of, it's not just, I don't feel like a little bit of bloating, a little bit of fatigue. This is, I can't function. I can't function. And you will have a question about this on the exam. Because the problem with this is most people won't catch it. And these patients will go on month after month after month after month in misery to the point where they're suicidal. And we don't want to miss that because we don't want to push these patients to that. So there's no blood test for this. And we've got to evaluate these patients on their signs and symptoms. And if you look here, you have to have greater than or equal to 5 symptoms that occur most cycles. Okay, when we have to have a period of time, a week or so, that things are better. You gotta have one or more of these, one or more of these, okay, and they have significant impact. This is DSM-5. Are we still on DSM-5?
Yes.
Okay, thank God. DSM-5 diagnosis. That's how significant this is. And that's how. I think when I trained, we had there was no DSM. Maybe DSM 0.5. Now we're at 5. So at least 2 consecutive cycles. At least 2 consecutive cycles. So oftentimes what we'll do, this is intentionally small. You don't need to memorize anything on here. But oftentimes what we'll do, we'll give our patients a calendar. I want you to take this calendar home. I want you to document when your symptoms are. And then bring this back after 2 or 3 months, and we can see X, 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 X. But I see a week of symptom-free. That's what I'm looking for. I've got to have, if they're just mean and grumpy 30 days of the month, this is not the problem. They're just mean and grumpy, right? But these patients are going to have that week of, I feel great. At least a week. It might be 2 weeks, okay? But then the symptoms come back, right? So that might be the best way for us to identify this by seeing it visually. How do we treat these patients? PMS, PMDD, both of them, we can do NSAIDs. We can do anti-inflammatories, okay? Both of them, we can do diuretics if we want. Now remember, HCTZ is not without other side effects. You know, it decreases your potassium, but a couple of days of some diuretics. If they're complaining, their main complaint is I'm swollen all the time, I'm just bloating during my menstrual cycle, we can treat them. PMDD though, the primary treatment, first line treatment is SSRI. For those of you that are going to insist on picking NSAIDs, it's wrong. SSRI is the treatment. Okay, then we can add other things to that. You can add the NSAIDs, you can add the diuretic. The SSRI is going to be your primary treatment, and then we can consider even something like combined oral contraceptive. Especially if we think that maybe the underlying etiology is that they're super sensitive to those changes in the hormone. We'll put them on a continuous progestin and estrogen progestin so we don't have those fluctuations in the hormone levels. Some patients, if they're still having severe symptoms, they'll consider GnRH agonists. GnRH agonists are okay, but the problem with GnRH agonists is they put these patients into a false menopause. And I am here to tell you, these patients are already not doing well. You throw them into a false menopause, definitely don't go in that room by yourself because they are fixing to fight. They're fixing to fight. And then Danazol, again, if you're having really bad symptoms, they can do Danazol. Usually that GnRH agonist, the Danazol, that is something for our consultants to put them on. We want them to be on the consultants now. Danazol tends to be poorly tolerated because now they start getting hair blowing out everywhere. Again, fighting words. Fighting words. Right. So we talked to our patients about decreasing sugar, decreasing caffeine. Consider calcium as well. Calcium actually decreases cramping. Okay, decreases cramping. Vitamin B6 it helps with mood. It's a cofactor in serotonin. Same thing with magnesium and vitamin B6 together. They can decrease anxiety. Vitamin D helps with the skin, and then omega-3 fatty acids. They think that can help with anxiety and depression as well. There are some studies that are going on about acupuncture, but there's nothing really clear and concise that acupuncture really works. But some, or even bright light therapy as well. But we don't have any really good retrospective control trials to tell us if we should definitely be doing that or not. But it's a consideration. Okay? So no sugar, no caffeine. And then when we think about the ultimate approach, this person's going to come in. Okay, like I've got breast tenderness, I've got sleep disturbances, my mood is up and down. Starts about 7 days before the menstrual cycle, which is that late luteal phase. Okay, so that's what their primary symptoms are. It's PMDD. They're going to say they are so significant that I can't function. It's PMS. It's important to identify that their symptoms are just mild but uncomfortable. Like you can still go to work, you just don't feel like going to work, but you could. Well, PMDD is I can't. If I go to work, someone might die today, right? So our treatment for PMD, SSRI is our primary, NSAIDs for PMS, and adjunct NSAIDs for PMDD, and our dietary changes. Okay? And that is it for today. This is you guys, it doesn't kill me. Give me a lot of maybe unhealthy coping mechanisms. But that all goes away if they